Good morning, everyone. I am very grateful today for you to join us at Signals and Symptoms podcast. And we have our good, amazing friend, Hansa. Dr. Bergava has actually had a significant long career in basically building trust in medical literature. And she's going to help us understand in the age of AI what trust in medical literature means. She's totally blindsided right now because I'm going to ask her very tough questions. As you know, this is how we do it. So just want to tell you that she has a long career from WebMD to now she's part and parcel of Helio. And then we're going to go ahead and basically jump into right away. So Hansa, do you mind actually reintroducing yourself to the whole our audiences that what's your journey been in the and how did you get to this point? And then we're going to start essentially the today's topic, which is architecturing trust in healthcare AI. And the idea is that how medical literature, which is by itself, we're going to come into it, authoritatively and everything, and discuss how we can move trust again, because honestly, we are losing trust in AI and healthcare because of the hallucination problem. So start with your journey, and then we'll move forward.
Yeah, well, Junaid, thanks so much for having me. I really appreciate it. It's exciting to talk to you again. And we met at AI Med, and that was amazing. And Harvey, hello, good friend of mine. Thank you for having me on this. Uh, Look, I mean, I'm a physician just like the two of you are, and I worked in clinical medicine for a long time, over 12 years actually, in many roles, and that included ER as well as hospitalist, as well as even, helping residents, training
Mhm.
residents as well, and a year in private practice. So I kind of took on a lot of hats at that point. I was also involved in leadership over there. And it's really interesting because some of the leadership I did was actually work on protocol committees for issues such as fever in a newborn or concussion pathways. And so those are protocols, and protocols are essentially what algorithms are, right? So, except that, we were looking at the research and the evidence for a very long time before actually doing this. So, putting together guidelines or policy statements or protocols for hospitals takes, a couple of years sometimes, right? And now here we are at this
Mm.
juncture where we can do that, in a snap, as we all know, because we can get the literature immediately, especially with the generative AI tools that we're using for physicians and scientists. And, the resources are right there. And the hope is that it's accurate. So I'm sorry, I just went off. But anyways, after that, I actually did kind of pivot to digital medicine, Junaid. And the reason I did that was because I was really frustrated with the health system as it stood. There are a lot of gaps in care.
Such a consistent story by every physician that I talk to, and it is not going away. So, tell me about your digital health journey a little bit more, so that we understand the background.
Yeah.
I do, but my audience does.
Yeah, absolutely. So I was fortunate to take on the role of medical director of a partnership program with WebMD and a large hospital system in the Midwest, Sanford Health, kind of looking at obesity. And we built up 3 websites. We built up an app. We built up digital tools to help patients engage where they were. So that's the problem, right? Like patients go into a doctor's office, they see the doctor for 15 minutes, and then the rest of their journey is just out there, right? And now, so using digital tools, you kind of follow them. And then I went on to build mobile apps. We did some partnerships with Apple, with Scripps. And basically, again, same idea, meeting the patient where they're at. That was at WebMD. And that way we could deliver trustable information. Junaid, I'm going to talk a little bit about trust here. I cut my teeth as a journalist at WebMD. Trust was the essence of everything they did. And it was super important to, have that trust. As soon as you lose trust, you have nothing. And that's true of any product, any publishing piece, anything else. And so we basically made sure that we took a lot of resources. We had unbiased content, And that, no matter what, whether we had partnerships with pharma or anyone else, there was a church and state. The way we built our content did not have bias. And so you can take those principles into anything today, right? And I do. Like when I write and when I produce content, when I build a product, it's super important to have authenticity and trust. And I've been really lucky to help Helio as Chief Innovation Officer, and I do strategic partnerships there as well. Help build their generative AI product, and I've also worked on partnerships over there. And again, the essence of all of it is trust and authenticity. I'll stop there.
Harvey, you're in and out because, by the way, Harvey, my bestie, is actually in Peru right now. So I'm going to let you first go into some first question, and then I'm going to start with my hard question.
Well, I'm honored to be here. I'm happy to see my friends, both of you guys. I'll say equally so that you guys don't feel awkward. But no jokes, all jokes aside, I really want to go deep with you in the sense that, what is your why? I know you and I talk a lot and we have a passion for AI and healthcare, but what is your why? Why are you doing this? And why should we listen to you? So tell me.
Yeah, great question, Harvey. Well, first of all, you have to listen to me because I'm your friend. Look, I mean, the why is very similar to a lot of our colleagues. We actually, I'm an optimist, and I do believe that most of my colleagues, my physician colleagues, have the same why, and that is we actually want to make patient healthcare better. And how do we do that? And for me personally, it was seeing patient care having problems, both as a physician, where they couldn't get access to care, or B, we were just running around seeing patients in the ER, not spending enough time with the patients because we were overloaded with EMR, or C, after the patient left the room, what happened? What was the follow-up? Did they actually take the medicines? I mean, I had patients taking the wrong medicine all the time because they just, they lost that. And D, like patient communication, like, when you give a patient a tough diagnosis, like the child in my patient room that I had to deliver the diagnosis of type 1 diabetes, or tell the parents their child had cancer, what happens? Are they actually getting that information, or are they so paralyzed by their emotions that they're not? So the why is huge, right? Whether it's for patients or it's for clinicians. The clinicians have been overburdened for years. We know that. We've seen the rates of burnout, and burnout still exists. So what if we've had a little bit of improvement? It's still up to 40-50%. Is that okay? That 1 in 2 doctors has burnout? And the admin load that they had. So there were so many whys. But as a patient, or having family members myself who've gone through the system, honestly, and I'm sure you guys have seen this too, I mean, it's been really tough with all of what we have seen and what I have seen. And just looking at some statistics, we went to AI Med, we saw the keynote speaker talk about medical errors, talk about medical reconciliation issues. So there's a lot of whys, whether it's for the doctor or nurse or it's for the patient, we need to make a difference.
Oh my God, so much to unpack right now. So let's just start with one by one and then make sure that we understand. So the problem statement today is that we can see that content generation is very easy, and high quality authenticated content is extremely hard. As a matter of fact, we still believe Helio and other platforms that the curation is done, and then we actually call AI slop, that is extensively going through social media and everything, which again erodes trust. It may be good. I'm just being honest. Some of the content is extremely high quality. I mean, I follow Harvey and you on LinkedIn just to understand. But some of the times you're using AI tools, and why not? Why are you going to sit there and do this? But then, that's the whole point of this podcast, Signals and Symptoms, that we can decrease the noise, increase the signal, and then put it back to the patient. So content generation is easy. AI slop is taking over the world. High quality content, now we come to that. So first, paint the picture for our audience again, that how much true clinical research is also slop. because people don't understand that clinical research, goddammit, is actually academicians trying to push publications so they can go from assistant professor to associate professor and everything. And that rat race of academics is going through to basically even the content that is on PubMed and everything may actually be slop. And then once you actually come to this, then you come to the true format before AI, the process of content generation, what you suggested, which builds trust, authenticity, etc. And then we're going to talk about AI. So do you want to give that sort of background to the community, our audience, that how does this look?
Yeah, I do agree with you, Janae. There's a lot of sloth out there. And, it's the tough task is to kind of filter through that and make sure that at the point of the question that the right content is being generated that is actually true and fact-based. I think the large language models obviously are drawing from all parts of the internet. And so I think it's a harder task. I know Agentic AI can make a difference there. But look, I mean, you've seen the articles about certain LLMs and patient information and how much there is accuracy. We've seen the cases of suicide or giving, the wrong information to an oncology patient, generated by certain LLMs out there. So I do think that the ones that are, medically based have probably a lot more trust in that they're only pulling from certain content. Now, to your question, Junaid, yes, they're pulling from PubMed. They're pulling from drug resources. They're pulling from the news, the health news that's out there. Helio actually. I'm proud to say Helio pulls from the most up-to-date news because they're attending 140 conferences and they're looking at abstracts, and they are a journalistic entity. So they have that, I think, leg over a lot of other organizations. But, other organizations like Open Evidence and, all that's out there are doing a good job in that they are pulling from restricted sources, right? And that's the ones that we name. We're not pulling from Joe Schmo's School of Medicine or Joe Schmo's opinion on vaccines. So I do think that's true. Getting to your question about PubMed today, look, I've published papers and it is somewhat of what you say, for sure. But I do think that there is some value to peer-reviewed journals and going through the evidence and looking at the data and having that rigor. So maybe I'm an optimist, but I do think the majority of information out there from PubMed, although what you said is somewhat true, is probably good information, right? Because there's a process, there's rigor, there's evidence. You got to pull that evidence, you got to show the proof, and then you get published. It's not easy to get published. So I would say the majority of that is good. And I do think that, we pulling from that data is far better than pulling from everything on the internet. So I'll stop there.
So first, I concur with you that definitely PubMed is better than the general internet. However, the question really is that I'm actually, part and parcel of, author reviews or whatever, like peer review committees and everything, including Frontiers. Unfortunately, what I'm seeing is that the more recent articles that I'm getting to review, the first step I do is actually make sure that I run it through my custom AI to ask them that, hey, was AI used to write this article in the first place? And then I would write to match it. And interestingly, we're seeing 60%, 70%. Again, that doesn't mean it's bad. What I'm saying is that Harvey is insane in the sense that what I'm worried about is that 10 years ago when I had to write it, I'm come from Pakistan. My English is great and overall, but still I would get an English grammar person to check my work before even I submit. The level of rigor that was required was insane. And they're like 6-month process. You're absolutely right. The minute I publish it, it takes 6 months to actually get it on the journal, which again is insane in this time range because now I've stopped actually publishing in peer-reviewed journals. Because I feel like, why? I go to MedArvics, I go to archives where, Stanford students are publishing in computer science, and part of mine is also computer science related, so I can publish it there. So interestingly, that flow is going towards AI generating more research, which is, again, we are actually looking at the advent of AI being at the PhD level. Then the second part is that publishing pipelines are getting broken. Um, just to be honest with you, I mean, your LinkedIn is more powerful to me than anyone else actually doing deep research right now, because that's coming from like true human intelligence. And if you look at similarly, Substack is one of the ways that I'm actually getting a lot of information now, is just understanding not just the research, but understanding why research is important and why it is going to go through. So there is this arc. Now, other published articles have been done, and they're stating that, you know, issues with actually medical evidence. First of all, negative trials don't get published. Nobody publishes that, which is the core important, most important thing. What doesn't work, in my opinion, is way more important than what does work. The second issue is that even with these rigorous approaches, as we are saying that it's stated that 30% is fluff or rewritten, or, you know, as I said, review articles, meta-analysis, and all of this sort of noise is coming in the market. And unfortunately, as I said, trust is going to be important. But this is where my thought process was, that even in PubMed, when I'm building my clinical decision support system, there's a very high degree of which articles are going to be added and why. So there's like a 16 level confidence interval process in which you're going to go ahead if you're going to do even clinic. And then the last point is, let's say you get a high quality article. Let me tell you, acute ischemic stroke guidelines. I actually was part and parcel way back when to, you know, carotid endarterectomy versus this. Most of the experts did not agree, even with clinical evidence present. And then when we were writing the guidelines, we were watering it down. Okay, there's a clinical evidence, but then experts disagree, so therefore the evidence is coming down. So this is such a huge mess of things when you go through this. But that comes to the opportunity part, because when there's a mess with the advent of AI, do you think all this mess is solvable, given that we now have this new generative AI technology, large language models, etc.? They can basically go through each and every line, mark it out that this is fluff, this is not, etc., and then get to the true summarization, which basically that summary can drive what we call clinical decision support at the point of care.
Yeah, I mean, a lot of what you say has, I do agree that there is definitely subjectivity, whether it's policy or whether it's publication. But I don't want to just, I think that we're walking a dangerous line if we just say, oh, well, let's just hand it over to AI. And the reason is that the human in the loop and oversight of the human, just being like having the blended intelligence, as one expert has called it, is super important, Junaid. And that is because, you can't, I wouldn't, like, yes, there's subjectivity with humans, but AI by itself is not something that we should also lean into. And let me just say a little bit more about that. So I don't AI, there's a couple of interesting articles that have come out about AI, right? Certain AI engines are built on user engagement. The algorithms want you to come back for more, right? And so what does AI do? They say, oh, yeah, like we're going to agree with that. A person asks a question and they want to be agreeable, because you and I both would rather hang out with somebody who's agreeable than non-agreeable, right? That's just human behavior. So there's that aspect of it. The second aspect is that, depending on where the AI is built and where the data is drawn from, and the data can change, right? Things change all the time. The AI can actually have that bias. So you're talking about subjective bias in publication policy. AI certainly can have bias too. And, the AI that's built in the United States might be very different than the AI built in China, for example, or even in Europe, right? With the regulations that exist in Europe. So the AI is going to be different wherever you go. And then, of course, culture, like you and I are from different cultures. Yes, we're, raised here, but, that cultural influence probably has some impact on how we, how we interpret things. And if we're building the AI, could that have bias in AI too, right? So I think it's it's a tricky line that we walk. So yes, it could definitely it will improve things. Absolutely. And yes, most of the time it will pull in objective data, but it's super important to have the humans involved in the loop because we just don't know, right? And certainly bias exists in all systems. Lastly, Junaid, you probably know more about this than I do, but there could be shifts in the AI algorithms too, right? With machine learning and also with data changing. I often talk about this in some workshops that I do, and that's like, the ERs during the pandemic for children were very different than the ERs for adults. So if we had algorithms based on volumes coming into the ER for pediatric ER, I mean, there was a lot of pediatricians let go from the ER during the pandemic. The kids weren't getting sick and they weren't showing up. So imagine an AI that's built on volumes in the ER, right? And then basically it shifts. And those are shifts that happen. So God forbid the next pandemic that comes, will our AI systems be able to withstand that? Because now the environment has shifted, and there's other data that needs to be taken. And hopefully they will, but I'm just saying that we have to be aware. I am a very big AI optimist, and I believe in AI, solving a lot of issues, but we can't just hand it over.
No, that was never the thought in terms of that hand it over. But human in loop is absolutely important in terms of trust. But the way that AI needs to function is that what I'm trying to accomplish, and I'll demo it to you, is that even the reviewer actually gets AI help and then confirms in a user experience that matters. Because I'm just being honest, I'm a practicing physician. I understand when to give aspirin, Plavix, when to recommend endectomy, when to call the surgical person, when to call the neurosurgeon. And there's this inherent, after looking at so many cases that I have, busting my ass. But the idea is that even at that point in time, for me to be provided clinical decision support, how does that actually look like? And more importantly, whoever is providing the clinical decision support, how did they make it? And that's how the sausage is made, in my opinion, is way more important than you're right. And the human, of course, is going to be part and parcel of it. I completely 100% agree with that. But what I'm saying is that the cognitive burden on the reviewer is also increasing. And then the last question is, people keep talking about clinical decision support, and I'm doing that. And the reason, to be honest with you, I don't think so that physicians sometimes don't need clinical guidance, just to very clear about. This is more of a CDI problem, clinical documentation improvement, so that they can, add the severity that they went into their head already, confirming it on a click, so that they can say, yeah, this is went through my medical decision making, and therefore I should be paid for it. So there's a different goal in my mind. But what I'm saying is that we're going to talk about how the sausage is made, and I think we need to bring the AI backwards, not just the content production with trusted sources, but more importantly, bring it back to the reviewer, and the reviewer can actually review with the help of AI, constant citations, etc. Just to remind everyone, Save Life AI has moved away from RAG, which is retrieval augmented generation. There's a lot of hallucination that happens. We call it what we call vectorless RAG. We actually do not curate. We take the actual thing, cite it, and then move forward. This is going to be released in the next 2 weeks and everything. But what I'm saying is that the reason that we are looking at these technologies in that depth is because whenever we run it, it's just stupid hallucinations come and I cannot release it. And then I have to restructure the whole tech back. And now I see the value given the recent technological advancements that are coming. Now let's go to the second step. And I'm sure you're probably appraised of it, but let me repeat it. FDA just said that clinical decision support through LLM, we are not able to regulate. right? They just said this is out of FDA's scope of regulation itself, which is purely where the first step of CDSS is actually content, which you are that's amazing work you have done. Thank you so much for the years. This is so important. And I'm going to come to the data shift problem and the model shift problem in a minute. But before we get into that more concretely for our audience to understand if they're building AI, I want you to address this elephant in the room. Like, what the hell? Like, FDA just said, thank you so much, can't do it. And this is where, what do you think the impact will be? Because it just seems like I can spend $100,000 on Facebook ads, build a platform, and that becomes trustworthy rather than actually giving $100,000 to actual human beings, reviewers, and get this done. I'm just putting the devil's advocate here.
Yeah, no, it's interesting. The FDA's definitely made a lot of changes and shifts in the last 6 to 12 months in terms of dealing with AI. I think it's a moving target, Junaid. So, people are just trying to navigate around it. And I do agree there's ramifications, and who knows, like maybe they'll come back and say that, no, we are going to be involved. I think, things are changing and they're trying to keep up with it. Interestingly, I'll also point out that different countries are doing it different ways. I mean, the European Union has, so many different ways of addressing this. I was looking at that yesterday, and some of those policies are going to take effect in August of 2026, right? And so, what does that mean? In terms of the global race of AI, and of course, and we've got China and other countries that are doing it different ways. So I think it's a moving target, and I think that. I think we can't see around the corner. I sometimes think about it as social media. When social media came out, Facebook and everything else, like, did we actually understand what was going to happen? Did we understand the extent that it would like literally shift the culture in our entire world, at least in the United States, both for families, for people, for children? And I know you're a dad too, and I'm a mom. What did that mean, right? And now all of a sudden, like 7 or 8 years ago, I did some talks on the impact of social media and tech on kids. And at that time, I said, one day this is going to be akin to nicotine. Like everyone was smoking a cigarette until we figured out that, oh, shoot, like cigarettes are really harmful. And now all of a sudden the science coming out about social media and the impact on, the young brain. So the point of that whole story is that, can we see around the corner? And I don't think that anyone can, whether it's the FDA, whether it's you, like as an entrepreneur and obviously an expert in AI, whether it's me with my background, whether it's the other doctors or even people on the street. I kind of worry about that, Junaid. And I also worry, honestly, just taking another point, yes, we've got FDA, we've got all these government entities, we've got CHI, we've got other organizations kind of trying to do the jurisdiction. But what happens on the ground? Like, what happens when the doctor actually uses the LLM? And especially the young generations of
doctors. Another problem, right? I mean, that's another thing. I feel like, Perplexity, Claude, and everyone just pushed it. OpenAI just pushed the clinician one.
Yes.
I mean, they're barely saying that, you can get a clinical, you can get a HIPAA. I mean, what the hell? I mean, this is optional now. I mean, there's some things that they're actually larger companies that are pushing through the system, which, to be honest with you, HIPAA is bullshit. Everyone should understand it is a BA agreement. Me and Hansa can just sign one agreement, and for some reason we are okay to share information, which is bonkers. And by the way, this actual regulation came in 1996. Do you remember? We were not even on Windows 7 in 1996. So I don't know why it still freaking exists. But having said all of that, I agree with you that that not only that this is an issue, but the temporal shift may actually be way more important as compared to what we are doing today. And then comes to the problem of trust again. And trust in an era with which, I'm just going to be honest with you, I mean, it's getting insane. I'm unable to keep up. And I read at 25,000 words per minute. I mean, I tested it. I'm upset, 2,500, I'm sorry. I tested it. I'm just saying that it is
I was
insane
going to
for
say,
me to
are you
keep up.
AI? When you said 25,000, I'm kidding.
So what I'm saying is that for material that I already know is darn good. For material I don't know, I test it on a regular basis, and I'm teaching my girls to actually read. But the problem really is that how exactly with this onslaught is going to happen. And coming back to the whole point of this podcast, how we improve the signal and decrease the noise in this era where honestly anyone with $1 million of chest from an investor VC fund can quote unquote up titrate their platform, and it just seems really odd place to be in.
Yeah, it's moving so fast, and that's the understatement probably of the year, right? And there was a great article, I believe it was on Substack, about how it's drinking from a fire hose. It's like, how do you actually ingest all of what's changing and all of what's happening as a human being? And even the experts feel that way. I know you do, Junaid, like you just said it, right? So I think there's again, we can't see around the corner, and it is so that's when you gotta. That's when you really have to make sure you have your anchors and your North Star, because if you're traveling this fast, like what holds you down, what grounds you, right? And I think that's really important to remember that. And again, going back to my North Star, I keep going back to it's like, I want to make a difference in patients' health. Like that's what grounds me. So everything comes from that. And therefore, like the information needs to be authentic. Therefore, the human needs to be in have oversight over algorithms. So I think there's a lot happening, and it's hard for all of us to keep up with it. But I think we have to always go back to what is our value system and what grounds us, and why. What's the why? Why are we doing this? And go from there. Yeah.
So I'm going to come back to this, but something just occurred to me. The future of copyright in the age of AI is a big issue. And I'm just going to be honest with you. One of the reasons that I've stopped publishing in these peer-reviewed journals is that, first of all, I never got paid for peer review, which is insane. And then on top of that, the same article, God damn it, I had to review, or actually I wrote, they're charging me to get that article. Are you insane? The article that I freaking wrote is going to be published on your website. I have to access it. I have to pay for it. It's just, I'm just like kind of, and then of course, I said, to hell with it, right? At the end of the day, I just needed my information out. And I just said, well, there are so many open source research articles that may or may not be peer reviewed. I can just say, I got friends, right? If they are going to do it free work from me, I can ask my friends to peer review it and write a letter that, hey, you reviewed it. So, and then this is one problem, that and even clinical guidelines are under copyright from some publications, which again, I know for sure, amazing experts with years of experience worked on it. And why is it not available? But that doesn't matter, because I'm just not really using that copy. I'm basically summarizing it like I would do for learning. And therefore, that summary is being used. So technically, it's not copyright, it's actually copy ad. That's another issue with medical literature in general and how this is going to progress. And then lastly, Helio is amazing. And of course, I trust you. And that's where it comes. I mean, I don't trust Helio, I trust Hansa. And that's where the trust problem also impacts. So the third one is, you said human in loop, but human in trust production. How is that going to be impacting in an era of temporal shift of data, temporal shift of model, and then, of course, this onslaught of so many things? So 3 questions. I apologize, but
no, of course. So Junaid, you said something interesting. I trust Helio, but I trust Hansa, right? That's what you said.
Correct.
So I'm just going to hit on that point. Thank you for that trust. What I was going to say is that is another reason there needs to be human oversight and humans in development. And I talk about this a lot. Like when there are AI products that are in healthcare, what makes me trust that product? And we also asked that as a survey question twice. And the AMA has asked this question too in their surveys. And the doctors, time after time over the last few years, one of the top 3 influencing factors is that there is a clinician, a doctor, a nurse at the table in the development of the product. Super, super important. Immediate trust for me. And investors have said, and savvy investors have said, the first question I ask is, was there a doctor or a clinician, in the development of the product? If the answer is no, then I'm not investing in that product, because what do they know? What do they know about the product? I'm not saying anything, like obviously the engineers and business guys and everything else are super important. But if you don't have a customer at the table, then how are you going to actually understand the product? And that's not the only reason you want a clinician. You also want it because Junaid, you know this, like there's so many AI healthcare products out there. Where do they fail? They fail in the implementation of it, right? And the scaling of it. You have the best shiny product out there. You can't implement it into the very complicated health system, right? Or you can't scale it. What do you need to implement and scale? You need doctors and nurses and clinicians, right? You need people to be your ambassadors, right? You need people to help you in the hospital system. So, and then lastly, the last part of why clinicians are super important in the product cycle is that what happens after you implement it? And there's workflow. You have to have somebody monitor it, right? That's where like shifts can make a difference. MLs can make a difference. Changes can make a difference. Who's going to be monitoring it? And you and I know that when we sign off on an AI-driven product, we are carrying the legal risk. There's been no conversation about that.
Oh my God.
What's
the frick, man?
Who's going to carry the legal risk, whether a hospital has the standard of care AI or not? Who is carrying the risk of that? So for all of those reasons, the human is the clinician that needs to be in the loop, right? And at Helio, like as a leader at Helio, that was something that was, a very significant part of my leadership. Let's do the physician advisory board. Let's get the doctors at the table. Let's have them actually vet everything we do. Super important in any product, Junaid. Yeah.
So Hansa, I completely agree with you. Just for my knowledge, for everyone's knowledge, anytime you're using these AI scribes, by the way, the Texas state now health service, whatever, from Texas, requires you to put a disclosure that, hey, I reviewed the documentation created by the AI scribe for accuracy. Voila, you are actually always on the hook. And not only that, you'll have to actually write a disclosure in the node. And this is going to be the problem in the future as well, as we see that a lot of AI slop is coming out of the market, and more of this information needs to be tested, fully completed, etc. So Hansa, last question of the day. 5 years from now.
Oh, geez.
That's too long, actually. You know what? 5 months from now may be enough. But you're right. Let's just say, I don't know, whatever time frame. Actually, let me go back. When Facebook launched and Instagram came, that was the overall 8-year difference. And that's shrunk. That sort of overall process is shrinking significantly. If you look at from GPT 3.2, which was quote unquote good, to now we are at 5.5.
Yeah.
That's barely 2.5 years. So just whatever future you think. What is the biggest risk? And what is the biggest opportunity you see in this space of trustworthy content becoming the baseline for clinical decision support, CDI, all of those?
Yeah, it's a great question. So I think probably some of the risks that I see are what we spoke about. I think that it's important for AI not to be completely in charge, that we need blended intelligence. We need clinicians completely involved from the very beginning to the very end, to every single day that they use the tool. Super important. I do believe, Junaid, that the younger generation of doctors and nurses might be at risk, just like our kids are, for automation bias and all kinds of bias. Like, eventually the human mind says, oh, well, the AI is right most of the time, so I'll just trust it all the time. I think that's a risk. I think the legal risks are
That's
real.
actually not the risk answer. I mean, there are actually now evidence that, GI physicians who are doing colonoscopy and polyp detection with and without AI, they actually de-skilled themselves. That study was not great, but there are now two more studies. Actually, I'll put that in the next meeting. I mean, I'm just telling you right now, as a stroke physician, I was trained to look at the CT angiogram, look at every branch,
Yeah.
where's the LVO and all of that. I mean, the new people are getting AI-based studies, and
Yeah.
then the new physicians are not. Right. Not only that, the old physicians are de-skilling. They're saying, "Oh, we need AI." I said, "Well, why? I mean, you have the image. I mean, it's not necessary. We used to do it for 50, last 20 years.
Yeah.
So, you're so on point that not only future generations will have a skill gap. The current generation is de-skilling. Keep going.
Yep.
I'm sorry, I had to say it.
I really think it's a risk, and we need to address it now. Like, these studies are coming up, but we knew it intuitively, right? Of course, every generation is going to be de-skilled, but how do we intervene? And I think that's where that question lies with the medical schools and, the CME organizations and all of that. How do we do this? What do we do? Like right now, the American Board of Medicine, and we all do our, board certification questions, ask, a few questions every quarter. How do we change that so that there's actually critical thinking involved? Very, very important, right? Whether it's a medical student, a resident, a fellow, or practicing physician, or someone like you and me, right? So that's really important. And I'm just going to extend that, Junaid, and say that's a risk also in the general population. I have heard many of my colleagues talk about how people come in and they're like, "Oh no, I need an ultrasound for this." I just wrote an article in Forbes about that. The navigation of miscommunication, and the belief that the patient might have. And I'm not saying they shouldn't use LLMs. Look, there's a lot of amazing stuff that they can actually get access to information. It's democratization of information, but be aware, user beware, right? The good is just the good. The second part of your question, the good is incredible. Like, AI is a tool. We can use it for good or we can use it for not good. And I think there's just so much. And we've already seen the capabilities of, the scribes. We've already seen the capabilities of point of care, like, Helio AI, Open Evidence, all of those, right? That can actually help the clinician. Personally, I would have loved to have that when I was in the ER. There's a lot of cases that I would see that I'm like scratching my head because it wasn't bread and butter. And I'm like, what am I missing here? And now we have the tool to help us that. So yeah, there's a lot of good, but I think we have to tread carefully. I'm sorry, that's just my nature. I mean, it's important to think before you leap.
I agree 100%. Alan, thank you for your amazing comments. I love it. You're absolutely right. At some point in time, we as physicians need to figure out what coders and coding companies are responsible for. They should become, at some point in time, liable, as physicians are. You can't keep everything shooting from my shoulder and using me as a thing. And I agree with the right. Learned helplessness is going to be something that is going to be an issue, as Hans has said, not for physicians, but everyone, as we democratize LLM usage, but more importantly, democratize and demonetize intelligence itself. What happens to my intelligence? And not only that, I am, as he correctly pointed out, learned helplessness. What happens to the generations coming forward? Because I'm stupider, clearly. No, I'm happy to admit it. I mean, that's the way that I used to do problem solving is very different, like hugely different than I used to do literally in 3 months. Right? I mean, I literally send out 5 agents, do research on my behalf, compiles the report, brings it in, then the code review is done and everything. And then I say, oh, well, these are the 5 ways that I can do architectural decisions on my tech. It's just insane. Things have changed so much.
I think it's important, Junaid, to make sure we lean in. I'm not saying don't lean in, but also use those skills, because if you don't use them, you lose them. Like, I will say 100% of my LinkedIn articles are written by myself.
Awesome. Love it. Mine are not. I'm just being honest.
I know. I'm not saying that you shouldn't use it. Yeah, I'm not saying you shouldn't use it. I'm just saying, like, you got to use the skills, but you also have to learn. It's a lot. Correct. It's a lot.
Absolutely. And then, yes, we are instituting at our home thanks to my wife, amazing wife, that we're gonna have no tech weekends.
Oh, I love it. Good for her.
Yes, so one weekend out of the month, not all, because I'm gonna get crazy what I'm gonna do. So, and then the other thing we're instituting is that I'm actually physically installed on my daughter's laptop, which is 11-year-old, how to use AI, when to use AI,
Yeah, you
basically
gotta use
develop
it.
her skill.
Yep.
And then on the same part, I'm just going to say, okay, now this problem you solve with AI, now solve it yourself, and then figure out the difference, and then sometimes solve it yourself first, and then solve it with AI. And the idea is that she understands how to solve problems with a tool and without a tool to
Yes.
increase. Correct.
Yes,
So
good parenting right there. I love that. I'm
again,
sorry, I'm a
I'm
pediatrician. So.
yeah, well, Hansa, when it comes to Dallas, let's come bring you at my house. I would love to, you to meet my wife, and of course, we'll get some amazing Gujarati food when you're here in
Ooh,
town.
I'm
So we'll
in.
go
I'm
from there.
in. Thank you,
Thank
Junaid,
you.
for having me.
No, I'm very grateful. Thank you, everyone, for joining. I appreciate it. See you next week, Wednesday at 8 a.m. Central Standard Time. Thanks. Bye.